This podcast is brought to you by The Recenter. The Recenter offers a unique blend of aesthetic and wellness services in an intimate environment that cultivates relaxation. Call 319-694-6086 to schedule an appointment.
Hey there, it's Dr. Andrews here with another podcast. So today we are going to talk about a procedure that is one of the most common procedures that we do in cosmetic surgery every year. Breast augmentation and liposuction are the most common procedures that we perform. And today we're going to talk about breast augmentation. Breast augmentation is a procedure where we either use an implant or fat to increase the size and shape of a woman's breast. For a breast to look shapely, it has to have volume, and that's you know there are different aesthetic standards, and breasts come in all shapes and sizes, but most women like breasts who have a fullness. And so one way for us to provide women with fullness is to place an implant. Another way that is nice, and there are some things that we can do with that approach that we can't do with implants, is using fat to increase the size of a woman's breast. There are some pluses to using fat, and some minuses. And one is the fact that we can't oftentimes inject a significant amount of fat into a woman's breast who has a small breast, because again, that's why they're coming to see us. They have a small breast, which means they have very little tissue to actually inject into. And so one of the downsides of that procedure is needing to perform multiple procedures to get people to their goals. But we're going to talk about that. We're going to show you some before and after pictures, and it's actually hopefully going to be a very comprehensive assessment of how we augment a woman's breast. So let's just talk about breast aesthetics firstly. For a breast to look shapely, like I said earlier, it needs to have volume. The other thing that the breast should have is it should have a nipple that is above the fold, and most of the breast tissue should be above the fold as well when you're looking at the breast, both from the front and specifically from the side. So if you've had kids, and you've lactated and your breasts have engorged, meaning the skin has stretched, or you have gained weight and possibly have lost weight, your skin has been stretched. And in those situations, you have what we call a ptotic breast or saggy breast. And in those situations, not only would you benefit from volume, but you would also benefit from a breast lift. But today we're going to talk specifically about women who come to see us for breast augmentation. So again, the most common way that we increase the breast size is by placing an implant. There are different types of implants. There are 3 implant manufacturers here in the United States now. There's a company called Sientra, a company called Allergan, and a company called Mentor. Now, there's some other implants like Motiva. There's some implants, some new implants that are coming that are going to have some advantages as well. But those are the 3 main companies that make silicone implants. Sientra does not make saline implants, but the other 2 companies do make saline implants. So we have silicone implants and saline implants. Silicone implants are great. What I like to say is most of the modern technology has sort of gone into making silicone implants. And so now we have the highly cohesive silicone implants. And so those are implants where the gel has been thickened, which has produced a number of benefits. Number one, they have lower rupture rates than the older implants, especially those when you compare to those old Dow Corning implants that had a really thin shell and a really thin gel. These newer implants have a thicker shell and a thicker gel, meaning if the shell is thicker, it's going to rupture less. And then if the gel is thicker, even if it ruptures, it's not going to leak out as easily. And so that technology has really improved. Now we're in 2023. The first quote unquote gummy bear implants were approved back in 2012. And those implants were really a game changer because they were the first implants. They were the Sientra implants, but they were the first implants that really allowed us to provide an augmentation where we were able to maintain the shape. When you stand one of those gummy bear implants up, it maintains its shape at the upper pole of the implant better than saline implants do. And that was really nice for giving women better shape and better upper pole fullness, which is one of the things that women want when they come to see us for breast augmentation. The second thing that those implants provided was less rippling. And so because gel has different levels of cohesivity, and that's the ability of a liquid to stick to itself and maintain its shape, you get less rippling. What I like to say is the only implant that won't ripple is one that's made out of wood or steel, and that would feel unnatural, be heavy, and not an implant that someone would want. So all implants are going to ripple when you stand them up, but the more cohesive the gel, the less you see that rippling. Saline implants are still used by certain plastic surgeons. They do have a little bit higher rupture rate. There is a greater chance for the rippling as that I noted before. And some people feel that they don't give the breast as natural a feel. The other thing that I've seen happen with those implants is because saline has no or very little cohesivity. It has some cohesivity, but not a lot of cohesivity. The implant can sometimes act as a water hammer on the breast, and a woman need a lift sooner because when that fluid moves up, the volume is displaced up, and then it comes down, and it can kind of over time kind of bang on the breast and stretch the skin. It doesn't happen in all women, but I have seen it, and it can be quite distressing to patients when it does happen. But suffice it to say, both silicone and saline implants can be used to increase the size of a woman's breast. The other thing that we like to talk about with respect, one thing I want to mention about silicone and saline implants is that sometimes I have women come in and are concerned about the use of silicone in implant manufacturing. One key thing to understand about both silicone and saline implants is that the shell of both of those implants is silicone. So the implants are described or characterized by what they're filled with, not by the use of silicone per se, because the shell of both implants is actually silicone. So that's an important thing that we talk to patients about with regard to implants. There is something that you can read about on the internet called implant illness, and we're going to do another podcast about implant illness and something called ALCL, anaplastic large cell lymphoma, and that's going to be quite informative. But suffice it to say that if you're interested in implants and you're adverse to having silicone, then you might want to question your interest in implants because both, like I say, silicone implants, silicone termed implants have a silicone shell and a silicone gel, but saline implants have a silicone shell. Next thing we like to talk about with respect to implants is where we place them. We can place them above the muscle, we can place them below the muscle, or we can place them in a plane called a subfascial plane. And there are different degrees of above the muscle and below the muscle, and we're going to go through that. But traditionally, what most people talk about is above the muscle or below the muscle. There are, in my opinion, many more advantages to putting them below the muscle versus above the muscle. But some people feel that putting them above the muscle or subfascial, which is a type of above the muscle plane, is useful in certain scenarios. The reason I like to put the implants below the muscle are many, or the reasons are many. Number one, it tends to age a little bit better because there is a little bit of a restraint for the implant, and it really doesn't have that sort of same effect on weighing the breast down over time. The other thing is it provides some coverage above the implant because again, women who come to see us for breast augmentation have small breasts and very little breast tissue. And so if you put the implant above the muscle, as we mentioned earlier, all implants ripple. If you put the implant above the muscle in someone who has very thin tissues, you can see some of that rippling. So putting them below the muscle allows for a little bit more soft tissue coverage and potentially can make things look more natural. There has been shown to be a decreased chance for something called a capsular contracture, which is intense scar formation around the implants, which is something that you really, really, really want to prevent when you have implants placed, because your chance of developing a capsular contracture once you have one and have surgery for it is higher than it was at your initial procedure. And so what I like to say in my consults is an ounce of prevention is a pound of cure with respect to capsular contracture, because capsular contractures tend to come back in women who develop them at all. And so numerous studies have shown that if we put implants below the muscle, the incidence of capsular contracture is lower. The other thing that's easier when you have an implant below the muscle is having a mammogram. And it just so happens that when they do a mammogram, if you have an interface in between the implant and the breast tissue that they're looking at with the mammogram, it makes it easier for the mammographer to see the breast tissue. And so for a number of reasons, most plastic surgeons in the United States like placing the implants below the muscle. There is something called the dual plane, which is the plane that I use, and that's where the upper portion of the implant is below the muscle and the lower portion is below the gland. And there are different ways of performing that procedure. There's dual plane 1, 2, and 3, and we have John Tebbets to really thank for developing that procedure. And it really allowed us to provide patients with a much more natural look, because if a patient has an implant that is totally below the muscle, sometimes the implants don't settle well. And we'll show you some photos of what implant settling means, and it really can take a breast that looks unnatural immediately after surgery and make it look more natural, just that process of settling. And sometimes if you put the implant, and this is something that was done when we were using more saline implants, is that you only had to make a small window in the muscle to place the implant, and you could place it in almost a total submuscular plane. I would see a lot of those women come back when those implants didn't settle appropriately. So that dual plane does allow us to provide better implant settling and help deal with some women who have a little bit of sagginess to their breasts to help prevent the need for a lift, because if we can get that implant to settle and the breast tissue to sort of move up, we can have a better interaction between where the implant is and where the nipple is, because to have a shapely, aesthetic, youthful appearing breast, what we want is the nipple at the most projecting part of the breast. So I'm going to say that one more time. To have a natural, youthful breast, you want the implant behind the nipple, meaning on average, you want half the implant above the nipple, half the implant below the nipple, and that's going to give you a nice, aesthetically pleasing breast. And sometimes doing that dual plane in a woman who has a little bit more sagginess, doing that dual plane will allow for those that interaction to occur a little bit better. So to wrap up, I like placing implants below the muscle. I think there are a lot of benefits to placing the implant below the muscle. The other thing that we like to talk to patients about is incision location. And so there are 4 places where we can make an incision to place a breast. The most common in the United States is use of the inframammary fold incision. And so if you take your breast lifted up, most women have a fold down there, a well-formed fold. We like that placement because it helps to hide the incision, but there are some other benefits to it. We'll talk about that. The other place to make the incision is the periareolar incision. So that's an incision on the breast itself. And we're really trying to get away from that incision. And I'll explain that to you as well. The third place to make the incision is in the armpit. And there are some plastic surgeons who make that armpit incision and really place the implant in a nice pocket and do that procedure very well. It's not a procedure I like. It sometimes can be hard to get a silicone implant through that incision, but it can be done. It definitely can be done, but it's easier to get a saline implant through that incision because the incision often is very small, and you have to create a tract to get the implant in. And then the last place is something that really should be an anachronism. It should be something that's not done, in my opinion, is placement of the implant via an umbilical incision. There are some people who still do that. I don't think most plastic surgeons in the United States are making that incision, but it is a very difficult dissection to do through the umbilicus, and it can be quite tough to make the pocket for the implant, and that really is something that, like I say, it doesn't sound like a great idea to me. So let's talk about the inframammary incision. Again, it's the most common location for placement of the incision by most plastic surgeons in the United States. One of the more important things is because it's been shown to be the incision that's associated with the lowest incidence of capsular contractures. So remember, capsular contractures where we form really intense scar around the implant, and it just so happens that when we make that incision below the fold, we decrease the chance for contamination of the implant during placement. And it has been shown that there is an association between contamination of the implant with bacteria and the development of capsular contracture. And it just so happens when we make that incision away from the nipple and away from the armpit, the nipple has bacteria, the armpit has bacteria. When we make that incision in the inframammary fold, we can decrease the incidence of a capsular contracture. The other thing that the inframammary fold incision allows is an incision that is less conspicuous. And so when we make the incision in the periareolar area, there is a telltale sign. Everybody heals differently, right? So in terms of scarring, so African Americans, Asians, Middle Eastern, people of Middle Eastern descent sometimes can develop hypertrophic or keloid scars. And so if you have an incision directly on the breast and you develop one of those types of incisions, it can be unsightly. And again, the inframammary incision can be a hidden incision. The armpit incision, like I said, it's sometimes difficult to create the pocket because creation of the pocket is very, very important in post-op breast aesthetics. When we place an implant, we don't want the pocket too lateral. You don't want it too medial. You want to be able to release your fold appropriately. You want to be able to dissect the pocket as high as you need to place if you're placing a larger implant. And it just so happens that making that inframammary incision gives you more degrees of freedom to really precisely create that pocket, which can be difficult with the armpit incision or the axillary incision. Not impossible. And again, there are many plastic surgeons who perform that procedure and can do a great job. And if you're looking for a axillary incision, definitely search out folks who do that procedure. And if you call our office, I can give you some some names of folks who do that procedure very, very well. But suffice it to say, it can be difficult to create the pocket. We also are concerned about bacteria, about potential bacterial contamination, but that's less of an issue sometimes when we use something called a funnel. But again, the inframammary incision is the incision that most plastic surgeons in the United States use to place implants. So the last thing we like to talk about is implant size, and that oftentimes becomes the most important issue or question for that patients have is what's the best size for me. We have patients who come in and have an idea of what size they want to be. Some women, most women, I'd say, that come to see us here in the Midwest want a natural look. They liked what their breasts looked like when they were engorged with pregnancy and lactation, and kind of want that look again. We have some women who want to upsize, so they've had an augmentation previously and want a little bit bigger look, a little bit more upper pole fullness. And we have women who clearly want a fake look. And we can provide women with all of those, especially in our patients who come to see us and have breasts that are a little bit higher on their chest. One thing I'd like to talk about with respect to breast aesthetics is something that we call the breast footprint. And I heard a talk by Betsy Hall Finlay, who is an opinion leader in plastic surgery. She's a pioneer in plastic surgery, and she's in Banff, Canada, and has published many papers and books about breast surgery, aesthetic breast surgery specifically. And I took, and I'm giving her credit for this, a set of pictures from a talk that she gave where she had four pictures of four different women who came to see her because they thought their breasts were small. So that's very important to understand. All these patients came in for a breast augmentation, but two of them had a high breast footprint and two of them had a low breast footprint. And where the breast is on your chest cannot be changed. And that's very, very important to understand. And so if you look at these pictures and you look at where the bottom of the breast is in relation to the antecubital fossa, which is here where we have IV or blood draws, we call that the antecubital fossa. You can tell a high-breasted woman has a large distance between the bottom of her breast and the antecubital fossa, and a woman with a low breast footprint has a shorter distance, and that's something that we cannot change. And again, like I said, where do we want the implant? We want the implant behind the nipple. So if someone comes to see us and they have a low breast footprint and they want a lot of upper pole fullness, that's not something that Mother Nature, I don't know what you believe, or God gave them the ability to have, unfortunately, because if we put the implant, if there was a way for us to put the implant really high on their chest, their nipple would be nowhere near the center of the implant, and they would have an odd looking breast, not the breast, as I say, not the breast that they paid for. So unfortunately, if you have a low breast footprint, we can make you better. We can make you look more attractive and give you a fuller breast, but we can't necessarily give you a lot of upper pole fill. Now, with that being said, we could potentially perform something called a hybrid or a composite breast augmentation, where we place an implant and then inject fat into the superior pole of the breast. And there we can give you more cleavage and we can give you more upper pole fill. But it's hard to do that with an implant if you have a low breast footprint. Here in our practice, we have a number of techniques that we use to really try and give a woman a sense of what they will look like after the procedure. And so we have different sizing systems that we use. So essentially, the way it used to be done with rice, and you would go in and see your plastic surgeon, and they would tell you to go home and fill either a plastic bag or some type of bag with rice at different volumes, and then you would put it in your bra and you'd put a tight shirt on, and you'd get a sense of what volume you would like, and you'd call the surgeon and say, hey, I like 300 cc's or I like 400 cc's. Well, implant manufacturers have actually produced these sizing systems, which really have been nice in helping women decide the size they want to be. So we have those systems here in the office. We have a couple of them, and it really can give you a sense of what you will look like in a garment. So in a bra and in a tight shirt or tight sweatshirt. We also use software. So there are different software systems. There's Vectra, there's Chrysalix, and there's something called New Look Now. And there are some plastic surgeons who developed their own systems, or some who just use Photoshop to do it. But there is software that can be used to give a woman a sense of what they will look like out of a bra. And so we use the silicone sizing systems, and then we also use software to show women or give them a sense. Now, again, when we do these software simulations, they're only a simulation. It is not 100% what you're going to look like, but it gives you a really, really good sense, and we validated it. And so we've had patients where we show their befores, their simulation, and their afters, and most of these systems are actually pretty good at showing a woman how their breast will look after the implant is placed. So again, if you come to see us, there will be 4 things that we talk about. Number 1, we'll talk about implant placement, meaning above or below the muscle. We'll talk about the implant that's used, a silicone versus a saline implant. We'll talk about where the incision is located, and we'll also talk to you about size. Many women have other questions, about the procedure. We answer all of them, namely about downtime. In our practice, we don't want women exercising for 4 to 6 weeks, but they can go right back to work. And we do use something called the Rapid Recovery Breast Augmentation System, where it is unique in our practice in that we identify the nerves that travel to the breast, and we use an ultrasound to do that. And so you have to work with an anesthesiologist who has the ability to use ultrasound and interpret anatomy. So we use that ultrasound to do that, and we have an ultrasound to do that. And so we find those nerves, and we bathe them in long-acting local anesthetic. These are called plane blocks, Plane. And it takes advantage of the fact that our bodies, in terms of our anatomy, are consistent. And we know that the nerves that travel to the breast run in certain planes with respect to where the muscles are. So if we can identify the serratus anterior muscle, the pectoralis major muscle, and the pectoralis minor muscle with our ultrasound, we can place local anesthetic in those planes and essentially provide almost an epidural-like situation in terms of sensation to the breast and to other areas where we operate in the soft tissue. So it can be done both for breast and abdominal surgery. And we use a medication called Exparel. And Exparel has been a revolution really in surgery, because it's used in various locations. I've heard of general surgeons who use it for hemorrhoid surgery. Hemorrhoid surgery can be some of the most painful surgery you can have, is what I've been told, and it's been a game changer there. I know the orthopedic surgeons use it for some of their blocks as well, and plastic surgeons use it when we do these plane blocks, because what the company did, and it really is kind of a revolution in chemical engineering, is they've taken a long-acting local anesthetic called bupivacaine, which typically lasts, and you sometimes get it at your dentist, that lasts about 4 hours, where they've taken bupivacaine and they put it into these little fat spheres. And what happens is that when it's deposited in tissue, the fat over time dissolves, and the local anesthetic is released into your tissues, sort of a sustained release, and it allows the medication with one injection to last up to 3 days. And so we're oftentimes able to get patients through these procedures either with zero narcotic or 1 or 2 tablets of narcotic just on the night of surgery to sort of stay ahead of the pain. We're not saying that patients don't take any pain medicine, because sometimes people do use Tylenol and Motrin, but they don't need narcotic, and so they can get right back to work. The other thing that we do is with our rapid recovery process is that we're very careful with respect to how we dissect the tissues as well. And we don't use drains, and so oftentimes, like I say, we can get patients right back to work after 1 or 2 days of being off. The last thing I will mention, and I've talked about this throughout this discussion, is capsular contracture. And again, it's something that we really, really, really want to avoid. And some researchers provided us with some guidance with respect to how we can decrease capsular contracture risk, and it's something called the 14-point plan, and that's very important, I think, for a plastic surgeon to adhere to. So if you are having surgery, it might be something to discuss with your plastic surgeon whether they follow the 14-point plan. There are some people who follow some of them. There are some people who don't believe in some of the things that are in the 14-point plan. I believe the 14-point plan. I think it is useful. It is not very onerous to adhere to all of the points of the 14-point plan, but it's things like doing careful dissection, right? I mean, that's good in any surgery that you do. Try to avoid touching the implant. I mean, that makes intuitive sense, right? That you don't want to contaminate the implant, and so if there's a way to do that by using funnels and being mindful of not touching the implant, not just kind of stuffing it in the incision, that sounds useful to me. Number 14 is something that makes sense, and it's something that orthopedic surgeons do, is giving prophylaxis before procedures that are associated with bacteremia. So whenever you violate either the skin or the mucous membrane, meaning having a dental procedure or some type of maybe GYN procedure or colon procedure where you're going to have a biopsy, whenever a mucous membrane is going to be violated, take antibiotics within 2 hours of that procedure. It makes sense because you shower bacteria when you're having teeth cleaning or when you're having some type of dental procedure. It only makes sense. So all of the things on the 14-point plan, I try my best to adhere to. And so again, if you're planning to have breast augmentation, it might be a discussion you want to have with your surgeon if they're going to adhere to the 14-point plan. If you have questions about breast augmentation, absolutely, you can call us and schedule an appointment. We'd be happy to talk to you about your goals and talk to you about how we do breast augmentation. Certainly, if you're planning to have surgery with someone, you want to look at before and afters, and you want to get a sense of whether that person has the experience to sort of give you, with your certain body type and breast shape, the look that you're going for. And I would also ask, I would ask your surgeon if they do blocks for the surgery, because it definitely increases the comfort and it makes the process so much better. We really have surprised a lot of our patients who have a lot of anxiety about having pain and spasms after surgery. These blocks tend to work quite well. As always, you can visit our website at drandrewsplasticsurgery.com. You can call us at 319-450-7619. You can also follow us on social media. We're on most of the platforms. We post a lot on our Instagram page and our Facebook page. Links to those pages are on our website. So again, thanks for tuning in. And our next podcast is actually going to be a podcast with a young woman who had a breast augmentation and she's going to talk about some of the things that she was concerned about when she came to see us, some of the questions that she had. She's going to talk about her experience, and we're going to show you her before and after. So that's going to be a nice podcast, and we really are appreciative to our patients who allow us to interview them, to video them, and also to show their pictures of their before and after, of what they look like before and after. Again, stay tuned in to our podcast, and we have many more podcasts coming. So thanks for tuning in.